Hmm?
Barokim Abayim, and a big warm welcome to all our guests tonight. Before we begin, I would just like to run with you the order of the evening and some technical tips on how to make the best of it. My name is Jay Chirara, and I'm the Vice Chair of the Jewish Representative Council, and I will be your chair for this Salford Healthy Communities event. You probably noticed that everyone is muted. Please stay muted, as the sound is very sensitive on these mics. If you wish to ask a question, please do so on the comments function. Our speakers, when they are invited to do so, will need to unmute themselves. The event is currently going live on YouTube, so we have a public record for those who are not present tonight. You can turn off the camera if you wish. But before I start, I would just like to set the scene for our audience. As we gradually come out of lockdown, as we remember last year and the difficulties that we had and we faced, we are mindful of the fact that many of us have had to deal with health issues that are not related to the virus. Men in particular find it sometimes difficult to seek help for certain ailments due to the sensitivity of the topic. Prostate disease is a case in point. And it is well documented that screening for this disease can save lives. But before I start, I would just like to let you know what the program and the order of the program will be. I will introduce our main speaker, who will give a presentation. We will hear from Martin Baker, radiographer and lecturer in health care, and from Mr. Cedric Knight, volunteer and speaker for the Macmillan Cancer Support. And we will also take questions after that. And finally, Dr. Jackie Lewis, chair of the Salford Healthy Communities, will make some concluding remarks and give a vote of thanks. And we aim to finish around 9:30 to 10 p.m. Mr. Gerald Collins, I'm sure, needs no introductions, in my opinion, but here are just a few words. Mr. Collins is a graduate of the University College, Cork, Ireland. Mr. Collins trained in Ireland, England, and Scotland, achieving FRCS Ed and FRCS Grad in 1989. Following the West of Scotland general surgical rotation, he specialized in neurology and performed his higher degree research and subsequent thesis in Stirling Royal Infirmary, affiliated to Edinburgh University and the Mayo Clinic, Rochester, and was awarded an MD in 1993. Mr. Collins is an experienced surgeon in general and cancer urology, having been appointed consultant in 1997. Mr. Collins has maintained his research interest and is now research lead and MD supervisor. Mr. Collins has also run the Northwest Regional Prostate Cancer Audit for the last 10 years. Mr. Collins is a urological surgeon with a special interest and expertise in cancer diagnosis, management, and surgery. Mr. Collins, the floor is yours. Please unmute yourself.
Now, Jay, thank you very much. Can you hear me?
Yeah, I can hear you.
Yeah, well, firstly, thank you very much for inviting me, for starters, to this discussion tonight. And yeah, we're not showing slides because I think slides can sometimes make things a little bit too formal and decrease interaction, which is not the purpose of the event, quite clearly. Jackie has asked me just to discuss a few topics to do with prostate cancer, both early prostate cancer and advanced prostate cancer. And she's come up with some very prescient questions. And I'm going to start at the top of her list because I think her first point is perhaps one of the most important. And that is, what are the typical symptoms of prostate cancer as opposed to benign prostatic hyperplasia, or BPH, which is a very common condition affecting more than half men over 60. So if someone has symptoms, the chances are it's BPH. So the question is, what are those symptoms that might alert the patient to cancer as opposed to BPH? Well, the most important point I can make about that is prostate cancer does not cause symptoms usually unless it's quite advanced. Okay, and the importance about that is you don't wait for symptoms with prostate cancer. Okay, so you have to try and do something else to diagnose it if possible. And you mentioned the phrase screening. That's controversial. Well, certainly, I suppose the term early detection might be more appropriate. Screening trials have shown different results in different parts of the world. So really, if you wait for symptoms, you are going to end up almost certainly with a condition that is incurable. So you have to look at being a little bit proactive as a man over 50, let's say. And that brings me to the next question or point that Jackie made, and that's to do with PSA. Now, PSA, most people, if not all of you, are very familiar with. It's a protein produced solely by the prostate. Prostate cancer tissue produces about 10 times more PSA compared to benign prostatic tissue. So as a result, it is potentially a very useful marker and test for identifying prostate cancer early. Now, before PSA existed, which probably was first used maybe in 1980, something like that. But prior to PSA existing, the majority of men with prostate cancer were diagnosed with advanced prostate cancer. Since the advent of PSA, that has been turned completely on its head, and now the majority of men diagnosed with prostate cancer have relatively early prostate cancer. So clearly, it is a very important test. And it is currently the best test available for picking up potential early prostate cancer. There's an element of controversy about it in that, like any test, it's got its pros and cons. It's not 100% sensitive. There are a few benign conditions that will cause a raised PSA level. But that applies really to any test you do. And while PSA, for some reason, tends to get a bad press, in my mind, it is the most significant marker in urology, perhaps ever. And there is no reason for someone not to have a PSA test on the basis that they're worried about its inaccuracy. Yes, results do need to be interpreted. And yes, that's what urologists are there for. So I would say to anybody over 50, contemplate having your PSA checked annually. And I don't really know how much detail you want me to go into about PSA, but that's the summary. It's a really fantastic marker, provided you're aware of its limitations. So if you have your PSA checked, then the next thing is what happens next. So PSA it's age related. So, a normal PSA level rises as you get older. So first of all, you have to interpret the PSA in terms of the age of the patient. If the PSA test is elevated for the age of that patient, well, the first thing I would recommend is that it is checked again 2 or 3 or 4 weeks later. If the PSA has been artificially elevated, and the classic example of that would be a urinary tract infection, then it can take up to 6 weeks for that PSA test to go down back to the normal level. And the point about a urinary tract infection is that's a common sequela of the benign prostatic hyperplasia issue. So if you check PSA in the presence of an infection, you'll have to recheck it 6 weeks later. And I think in terms of medical practice, you should never hang your hat on one abnormal test. If you get an abnormal test, always confirm it. Now, the other thing to reassure people about regarding prostate cancer is it's one of the slowest growing tumors in biology. So there is no panic about waiting a few weeks or more to repeat a PSA. And if the second PSA confirms the first, then in that situation, the patient will be referred for further assessment. The investigations are, well, there's the basic investigation, which is examination, which obviously is not particularly pleasant, but it's not particularly unpleasant. It takes 2 or 3 seconds or whatever. And then, as Martin will be talking about, the standard first investigation currently is an MR scan. Now, there's currently a national pathway out there where patients who do get referred with a raised PSA go straight to test. That means they get their MR scan before they even see the urologist. Personally, I'm not a huge fan of that pathway. I think it's slightly over the top, but it is what it is, and that's what's happening currently. So when we see the patient, they've already had an MR scan. If the MR scan identifies an abnormality, then obviously one has to consider whether that patient merits a biopsy. And again, you've got to factor in the whole patient in terms of age, comorbidity, etc. And MR scans certainly have their limitations because they're a relatively new technology, and radiological understanding of MR scans is evolving. And one of the problems with this new pathway is a lot of younger patients, and I say younger as in under 55, are having MRs. Now, prior to this, very few patients under that age had an MR. And actually, the characteristics of the prostate on MR differ considerably between younger and older men. So it's very much an evolving technology. The issue regarding biopsy is done under local anesthetic. There are a couple of different techniques. It's slightly controversial at the moment as well. They are similar, of course. They have similar side effects. The main traditional biopsy was a transrectal ultrasound-guided biopsy. The newer technique is called a transperineal prostate biopsy. It is a bit more unpleasant for the patient. It is currently very much in vogue because many people out there believe it carries far less of a risk of infection. In fact, the risk of infection is only marginally less, as it turns out, and the risk of infection by both techniques is, risk of serious infection is less than 2%. So, we would all generally consider that an acceptable risk for any invasive test, really. So there are two ways of biopsying the prostate. One or other can be preferable depending on where the abnormal area is that you want to target. But they're both outpatient procedures and usually very well tolerated. And then it takes a couple of weeks to get the results back. Now, I said before the PSA era, the problem was the majority of people were diagnosed with advanced prostate cancer. One of the problems with the PSA era initially was because the majority were being diagnosed with early prostate cancer, there was initially an element of overtreatment. In other words, there are early prostate cancers that will never be a threat to the patient and therefore do not need to be treated, they just need to be monitored. But as a urological community, we copped on to that, if you want, and now our selection of patients is much more stringent, whereby the majority of patients who don't need treatment don't get it, and the majority of patients that do need treatment do get it. The patients you don't treat are usually put in an active surveillance program, which is a very hands-on surveillance, and there's really no risk of that patient developing a more serious version of their cancer without it being picked up by their urological team. And that leads on to the watch and wait, or the point that Jackie made. So there are three categories of prostate cancer on diagnosis, really. There's the low risk category, the intermediate risk, and the high risk. And they're very clearly defined categories. So a low risk category patient will be observed. A high risk category patient clearly will be encouraged to have treatment. Intermediate risk in younger patients, particularly with a life expectancy of more than 10 years, will generally be guided towards having active treatment. But again, it has to be customized to the individual patient. Her next point are treatment options. So I'll discuss treatment options for early prostate cancer initially. And then I just want to talk very briefly about advanced prostate cancer, because that's a very important happening area. But fundamentally, if a patient with early prostate cancer has treatment, there are two treatment options. They are both equally effective and they are both entirely different. So it's very unusual in that respect. So there are two treatments that are dramatically different but equally effective. So that's confusing for a patient, because can be a difficult choice to make. Option one is surgery, where we remove the prostate. Now that used to involve about a week in hospital, and now involves usually only one night in hospital. So that's a huge improvement in that. The other option is radiotherapy. Now, radiotherapy can be given two ways, either as an outpatient procedure where you shine X-rays at the prostate, or a procedure that does require an anesthetic as a day case where you put radioactive implants into the prostate, or sometimes a combination of the two. But already you can see they are radically different treatments. But as I emphasize, they are equally successful. And they are radically different, which means, of course, also they have different side effects. And that's another thing a patient has to factor in to the decision that they make. And the side effects regarding surgery, the main one would be erectile problems. And that side effect is higher with surgery than with radiotherapy. Specific side effects of radiotherapy would be it is radiation, therefore it does cause irritation of anything in the treatment field. So when you're having radiotherapy, you will get irritation of bladder and bowel. And that irritation can persist in a very unpredictable manner. So you cannot tell any one patient, oh, it'll settle down the minute your treatment's over, or, oh, you'll be having problems in 2 years' time. That is unpredictable. And that's, I think, a side effect that can be a significant issue. And the only other thing to bear in mind with radiotherapy, it is radiation, so there is actually a small risk of getting a secondary cancer from the radiation, for example, in bladder or bowel. Now, that risk is small, but nevertheless, patients need to be aware of it, so that if they do develop symptoms pertaining to either bladder or bowel, they must get those investigated. So that is for some patients, that can be a very difficult decision to make. The radiotherapy seems less invasive and it's more outpatient, but then the side effect profile is different as well. But either treatment choice is a perfectly good choice. Um, Jackie was asking about innovations. The main innovation, really, I mean, there are various exotic potential treatments for early prostate cancer, but there's no doubt really that surgery and radiotherapy are by far the two main, validated treatments. So I'm not going to go into really the exotic treatments because they're not really validated in my view. But the main development in surgery, in particular, has been the advent of the robot. And the robot, all prostatectomies now are done robotically. And that's the reason for just one night stay instead of 4 or 5 days or a week. It's because it's just, you get a much better view, much better access, much better bleeding control. It's a much more precise procedure than doing it with the naked eye. So the robotic approach is now the norm, and it's unusual. Well, I would think very unusual for a institution to perform open radical prostatectomies. That would not really be considered acceptable anymore. So that's I think all I'll say. There's no point getting into too much detail. I just want to give people a feel for really a bit of an insight into the whole thing rather than nitty-gritty detail. And I hope I've sort of done that with early prostate cancer. And I'm just going to briefly talk. Yes, I didn't mention other diagnostic things to do with genetics and all that. I'm going to briefly mention that because the whole genetic, I mean, you know, there's a national genome program, and the whole genetic profile of tumor is going to become very big at some stage. Because in theory, by doing a simple cheek swab, you could identify potentially any tumor anybody was at risk of getting at any time. And there are a couple of genetic anomalies called the BRCA gene anomalies, which are particularly relevant to prostate and breast cancer. So I think genetic profiling is definitely something that's going to be on the increase and potentially very helpful. It also can direct treatments as well. So that's early prostate cancer. Now going on to advanced prostate cancer. Very little happened in the treatment of advanced prostate cancer for maybe 70 years. And the standard treatment for advanced prostate cancer, where patients had secondaries, was what we call hormone treatment. And the point about that is prostate cancer cells rely on testosterone to survive and to thrive. And if you cut off supply of testosterone to a prostate cancer cell in a bone or a lymph gland, it will go into remission. And that was the standard treatment for maybe 70 years. That has been a really happening area in the last few years. A few new drugs have been developed which have changed the landscape completely. They are highly effective. They've improved survival dramatically. And on top of that, there are probably at least 25 more drugs or agents, let's say, coming down the tracks that offer a similar promise. So something that was relatively only had one treatment now has potentially many treatments. So these are huge developments. So whereas before it was incurable and that was that, now this is something that's actually become very treatable. And the other issue to do with that, immunotherapy is another area that's, you know, really, really taking off. And that's going to become very important in all cancer managements. And the other area that I think we're making great strides in terms of the advanced prostate cancer patients is looking after the rest of the patient or whatever, because we now know, and we've known for some time, that bone protection and bone health is particularly important in advanced prostate cancer. Now, these patients generally have weak bones anyhow, and the hormone treatment for prostate cancer makes those bones weaker. And it's fairly likely that these weaker bones are more susceptible to getting secondaries than a very strong, healthy bone. So the whole area of bone protection is becoming increasingly important. So we're looking after bone health now from day one. So we check patients' vitamin D levels. We do a fracture risk assessment, I think called a FRAC score. And depending on the outcome of those two tests, we pretty well always put patients on calcium and vitamin D. And we frequently put patients on bone protection agents called bisphosphonates. And they can be in tablet form or intravenously. So that is a very important development in this part of the world in terms of improving outcome and almost certainly survival as well in these patients. And interestingly, in breast cancer, it's been established for a long time, but for some reason, it hasn't been in prostate cancer. And those two cancers are very much the male and female of each other. Very, very similar hormone-sensitive tumors. And I think that's probably as much as I will say for the moment, I think. Thank you, Jay.
That is wonderful. Thank you very much, Mr. Collins. I'm sure the audience will join me in thinking that we have learned quite a lot tonight, and there are lots of questions that would come your way as well. But before we ask the questions, we will hear from Mr. Martin Baker, radiographer and lecturer in healthcare. And Mr. Baker, the floor is yours. Please unmute yourself.
Is that better? Can you hear me now?
I can hear you.
Sorry, my headset's broken. Okay. So good evening, everyone. Thank you for attending. I've myself have been fascinated so far by Mr. Collins's talk, and it's very, very interesting. So from my point of view, I'm a radiographer. Specifically, I do MRI scanning. I also lecture in advanced clinical practice at Bolton University. So one thing I wanted to do this evening was just to talk through the scanning procedure for MRI for prostate, in case anyone wondered what went on if you went for a scan, in case you were scared or just interested. I'm just going to run through the procedure just briefly with you to explain what goes on. So really the best imaging technique that we have at the moment for looking at the prostate is an MRI scan. So the information from this is used together with other clinical information such as blood tests, PSA we mentioned earlier. And with all this information together, it gives a picture of how healthy prostate gland is. So like I say, MRI scanning is really what we call a gold standard, the best way of getting pictures of the prostate. So when you attend for your scan, just standard MRI things really I'm going to be talking about. So you'll need to change into a hospital gown. Some places will allow patients to bring their own clothes with them to change into. So if you do this, just make sure there's no metal on your clothes. So zips, poppers, those kind of things, or loops where if you've got jogging trousers, loops where the cord goes through, anything like that. So you can quite often bring your pajamas or something like that if you prefer. It's always best to check with the hospital first anyway if you're not quite sure. So you'll need to fill in a safety form as well before the scan. So there's some things which really are contraindicated, so they're not allowed in an MRI scanner. So people with a pacemaker or other electronic devices attached to their body or some other implants may not be suitable for MRI. If you're concerned about this, if this applies to you, again, phone up the hospital, speak to the MRI department before you arrive, and they should be able to make the relevant arrangements. If it turns out that you can't be scanned because of this, then they may decide to do a different kind of scan, possibly a CT. But it's always good to sort this out before you actually turn up for your scan if you are concerned about it. So you may also be asked for a blood test before your MRI scan. So this is checking the health of your kidneys, because for this particular kind of scan, you will be given an injection in your arm of contrast agent, or some people call it dye. So this will basically check the health of your kidneys and make sure that it's okay to be giving this contrast injection. Okay, you'll have to give your weight. I know some people are sensitive about giving their weight, but you'll have to give your weight. Again, it's a safety thing for the scan. Also, you'll need to go to the toilet before having a scan. And some places, not all, may give an injection just to stop bowel movement temporarily, so that it may make the images clearer. Not everywhere does this, but some places do. Okay, so that would just be a very small injection for that if they do use it. For the scan itself, for the MRI scan, you'll be lying on your back. You'll have a device placed over your pelvis. It's a bit like a tray, perhaps a curved tray over your pelvis. It's not particularly heavy. And you'll have a cannula put in your arm to allow this injection to take place during the scan. MRI scanning is noisy, so you'll be giving some ear defenders or earplugs. And if your concerns during the scan maybe feel unwell or something like that, or something else, you're not feeling right, you will be given a buzzer, which is an emergency button. You just press it and the radiographer will stop the scan and come in and check that you're okay. So some people, when they're in the MRI scan room, they feel a bit lonely because there's no one else there with them. But you do have this buzzer which can alert the radiographer if necessary. So this, in terms of the scan length, this should normally take a maximum of half an hour for the scan. Some places it's shorter, but the guidelines at the moment say it should take no longer than half an hour for the scan. The only time it may take longer than expected is if the patient moves. So it is important that you keep still during the scan. So sometimes my patients, if they're a bit fidgety in the scanner, I may need to repeat a section, not the whole scan, but just a part of it, maybe 5 minutes or so, depending on how well they're able to keep still. So if you're actually going for an MRI scan, some people go privately for these scans as well. Just make sure that you get the right kind of scan. There are slightly different kinds of scans for the prostate. The one you need to ask for is a multi-parametric scan. Okay, this is, at the moment, we have, it's the best kind of scanning that we have with MRI. It's called multi-parametric scan. Not everywhere offers it, so just make sure if you do request a prostate scan that you do ask, you make sure that it is a multi-parametric scan. So apart from the injection in your arm, or this cannula being placed in your arm, there shouldn't be any pain or discomfort from the scan itself. Like I say, you'll just be lying there on your back in the scanner. You don't need to hold your breath. I know some people get concerned they may not have a good set of lungs on them. There's no need to hold your breath for this kind of scan. There is for other kinds of scans, but not for this one. So you just breathe normally. So what else is there? So I think that's mainly it, really. So the main thing, I think, as well now, things are moving along, the technology is moving along. So as Mr. Collins rightly said, MRI scanning, the techniques we use for MRI scanning are changing as new technologies become available and more evidence is available. But as far as we're aware now, MRI scanning is the best way to have a look without being invasive. There are some other ways of looking at the prostate. So some people that have prostate concerns go to a urology clinic and they may have problems in urinating. And actually with ultrasound, we can see the prostate. So some people have an ultrasound of their kidneys and bladder. And whilst that's taking place, the sonographer will also be looking at the prostate. And we can measure the size and the volume of the prostate and the outline of it, and also check the inside of the bladder as well. So we can see some things with ultrasound, and it may be a useful pointer for patients if they need to go for further investigations. Ultrasound can give some more information. But in terms of this type of scan that we're doing, MRI is certainly way ahead of ultrasound. So that's it, really. I'm happy to have any questions at the end or emails if you like. I did also mention, I did set up an email address if anyone wishes to send an email there is an email address I set up. It's prostatequestion@hotmail.com. So prostatequestion@hotmail.com, and we'll pass that query on to the relevant person for those of you that don't want to ask a question on this particular meeting. Okay, thank you very much.
Martin, Mr. Baker, thank you very much for this really fascinating walk through the technicalities, the practicalities of having a scan done. I'm sure many of us have learned a lot and feel much more comfortable now going through the procedure if we have to. And as you said, your email is on the chat there. So we've heard from Mr. Collins, we've heard from yourself regarding the scanning procedures, and now we will hear from Mr. Cedric Knight, who will share with us some of his experiences. Mr. Knight is a speaker for the Macmillan Cancer Support. Mr. Knight, the floor is yours.
Thank you.
Please unmute yourself. Oh, you're all right.
I am unmuted already, yes. My cancer diagnosis dates back to 2005. So some things that we've heard from the experts that have developed since then may override my experience, but all I can do is share my experience. My cancer diagnosis story started with a fairly routine appointment with my GP, where he was just checking various different aspects of my health. And during the course of the conversation, I happened to mention to him that my father had been diagnosed with prostate cancer and was being treated for prostate cancer. That immediately, at my age at the time, which was 56, triggered with him the idea that maybe he should arrange some checks. So he arranged for a blood test for me, a PSA blood test, and that was, I can't remember the number, but it was a high level. And so then I was referred fairly quickly. I was living in Macclesfield at the time. I was referred fairly quickly to the specialists in Macclesfield Hospital, where they made a bit of an examination and concluded that it might need more to be done. So then they sent me off to another local hospital where they performed a biopsy. I guess some of the other options that were mentioned earlier on weren't available at the time. And the biopsy detected, confirmed the PSA result of prostate cancer. I think it was probably a week between going for the biopsy and getting a phone call from the specialist at Macclesfield Hospital saying, you need to come in with your wife. And so I did. And so he conveyed the news that I had in fact been diagnosed with prostate cancer and that he would refer me for treatment. His first option for referring me to treatment was to refer me to the hospital in Stockport. At the time, I don't know why particularly, I just said to him, couldn't I go to the Christie? And he said, since you've asked, yes, you can. So I was sent to the Christie, and I was again there within a couple of weeks, and started to have some of the tests there, including the scan, which can't have been at all uncomfortable. I don't remember it at all. Well, it having been described again now, it brings it back to me, but it wasn't at all uncomfortable, and was part of the diagnosis process. After that was done, I had then a meeting with the consultant. I don't remember being given a choice between treatment options, but I probably was. At that point, my wife and I were both just a little distressed, I guess, at the diagnosis. But however, I arrived at how we arrived at the decision, we opted for radiotherapy rather than surgery. And so radiotherapy again started very quickly after that, probably within a couple of weeks. So that was at the Christie. I was travelling from Macclesfield. I was driving. My wife was with me most of the time. Can't remember exactly how many day visits I had to make for the radiotherapy, but I was fine driving myself for the first half of that period. But then halfway through the period, I was on my way to the Christie one day and got completely lost in Wilmslow en route. And my wife took over the driving from there on for the rest of the radiotherapy treatment sessions. They came to an end. At some point along the way, I had a discussion with the Macmillan nurse who explained some of the ongoing consequences, if you like, which is one of the reasons why I'm now volunteering for Macmillan, because of the help and comfort the Macmillan nurse gave to me and my wife after the diagnosis. So I then went back to the Christie every 3 months, I suspect, for 5 years for further checks to see that things were in order. After 5 years, they discharged me from the Christie, said I still needed a regular PSA test just to check if things might be coming back. In terms of side effects, I had immediate side effects affecting bladder and bowel. Because the radiotherapy is in that area, it does affect both. And even now, 15 years later, I still have problems with my bowel as a result of the radiotherapy that was given me then. It's under treatment, I'm on tablets for it, but it's something that I always have to keep an eye on. And then in 2010, I was discharged from the Christie back to the care of my GP. I was given a PSA level. If the PSA exceeded this level, which I won't say because it might not be the current practice, then I should immediately ask for a further reference to the specialists. I just had my last PSA test probably 2 weeks ago now. I always ring up for the results. I always ask for the number rather than just be told it's normal. And I was pleased this time that the number was exactly the same as the number was 6 months ago, despite in the intervening period having had a urine infection, which I didn't realise was one of the things that could trigger prostate cancer coming back. So that's my story. I think the only bit of it that's in addition to what the experts have said was that first referral, which was because I mentioned that my father had been diagnosed. It got me into the process of being diagnosed. Thank you.
Thank you very much, Cedric. That is really kind of you to share that story with us. I'm sure that people can relate to it, and it could be any one of us really who had to go through what you had to go through. And it's wonderful to hear that there are people such as the Macmillan Cancer Support that is there for people when they are diagnosed. We are getting some questions, and what I will do is I will begin by asking questions to Mr. Collins, and then to Mr. Baker, and then to yourself, and then I'll open it up to the audience. If anyone wishes to ask further questions, please just put your hand up, and then you will have the opportunity to speak. First of all, I will turn to Mr. Collins, and as I was listening to what you had to say, Mr. Collins, I was thinking, is there any hope? Do we have any hope of beating this thing altogether? Like now, we had the vaccine for this dreaded virus, and we were able to find something for it, and now it's slightly different, but the analogy is there. is there anything on the horizon in terms of genetic advancement and so on that could give us hope that we will be able to achieve certainty with regards not only to prostate cancer but to any cancer?
That's a good question, difficult question, really. I mean, I think in terms of prediction, diagnosis, yeah, it's all happening in that area. In terms of being in a position whereby you can identify somebody who's likely to get it, and then you can intervene and prevent that happening, currently, I think the answer has to be no, actually. Now,
Yeah,
part
so
of the issue is, of course, the population life expectancy has increased considerably. A lot of older patients are now being diagnosed with it that may not have been before. But in terms of cancer vaccines, I mean, it's a very exciting potential area, but there's no practical, to my knowledge, no practical things happening yet that would suggest that we might see that in my lifetime, for example.
yes, that is the general feeling that is around. It's very much, we were able to beat the virus, but cancer is still around. We did have some questions that came through chat, and I will take the first three of them, and we'll see how we go from there. The first one, just wanted to know, again, perhaps you have, and I'm sure you did, around symptoms, what they are. And the second one was very much around any nutritional advice or adjustments if the PSA levels are too low. And finally, there was a question regarding how reliable are the PSA tests themselves, and when does one refer oneself to a GP and so on? Okay,
firstly, but to look at the diet issue, there's no question diet. You're talking about raised PSAs more than low PSAs, obviously, but yeah, there are certainly dietary maneuvers that are definitely beneficial in terms of prostate health. And we do give out diet sheets to patients on a regular basis with benign prostatic disease as well as prostate cancer. Things like zinc, selenium, things like that definitely are very good for the prostate. And putting it very broadly, the diet sheets we give out, you're talking really about a Mediterranean diet, salad, vegetables, green vegetables, tomatoes, cooked tomatoes, raw tomatoes, ketchup, because they all produce lycopenes in a different way. So yeah, there's no question that diet is important, and the incidence of prostate cancer, for example, is much higher in the Western world than in the Eastern world because of the processed food in our diet and a lot more fatty foods in our diet. So your fish and chips type of diet is certainly not healthy for your prostate. Doesn't mean you can't have them, but there are people out there who eat virtually nothing else other than processed fatty foods. So they are, no question, they are risk. That is a risk factor for your prostate. And indeed, interestingly, the statins which people take to lower cholesterol, there's been some evidence suggesting that they actually, again, are prostate protective. So yes, diet, very important and well proven. A lot of people take dietary supplements. They vary considerably. Obviously, for most of them, there's no evidence as such that they're good, but most of them do contain one or two elements that we know are beneficial to the prostate. And you have things like saw palmetto. Again, that's very similar to some of the drugs we use for benign prostate enlargement, and saw palmetto contains similar agents. So yeah, there's no question diet has a very important role to play, both in reducing your risk and indeed in improving your prognosis should you be unfortunate enough to be diagnosed with prostate cancer. So yes, very important. So that was your first question.
Yes.
Yes.
And the second question was around symptoms. So someone wants a clarification on the symptoms to be sure.
Okay, so classic prostate symptoms, okay, are people going more, getting up at night, weak stream, standing there for a few seconds longer to start peeing. Classic example being, let's say, go to a match and there's three guys standing at urinals and one guy's feeling uneasy because he's there a lot longer than the other two. So they're classic prostate symptoms, but they are classic symptoms of benign prostatic hyperplasia, which is far more common than prostate cancer. And therein lies the rub. So those symptoms almost certainly point to a benign prostatic issue. And specific cancer symptoms generally don't appear until the cancer is spreading. And symptoms often first present not from the prostate itself, but from secondaries from the prostate cancer. So it's very important that people are clear on that. So symptoms from prostate cancer are usually a sign of advanced disease. So your standard prostate symptoms are usually benign prostatic enlargement, which is ubiquitous. Now, to make the point about that is, however, if you have those symptoms, you shouldn't ignore them. You should get that diagnosis confirmed. So you should see your GP. And you should have your examination and have your PSA, which will almost certainly be normal. And then your diagnosis is confirmed that, yes, this is the common problem of getting older for males, benign BPH, let's call it. So if you have those symptoms, you should get them checked out, but they are benign symptoms. I hope I'm clear about that.
Yes, thank you for that. That was really comprehensive, and it has prompted people wanting to have a copy of the recording, because it's so important what you're saying to us tonight in terms of valuable information. Someone also asked how reliable the PSA tests are in themselves, and when does it trigger a referral?
Right. Well, okay. I think the way to answer that is the limitation of PSA is what's called positive predictive value and negative predictive value, and that is, if you have a normal PSA, does that mean you don't have prostate cancer? Well, the answer is no, it doesn't, because unfortunately, some of the most aggressive prostate cancers produce very little PSA because the cell types are so primitive, they don't even produce PSA. If that makes any sense. So does a normal PSA, absolutely exclude you having prostate cancer? The answer is no, it doesn't. But a normal PSA, in addition to an examination, almost certainly does. Okay? So that's a pretty unusual scenario. So you've got to look at the more common scenarios. So the next question is, well, if your PSA is raised, does that mean you have prostate cancer? Well, it depends on the level, and there are different statistical rates you can be given for each level you have. As I referred to before, there are non-cancerous things that cause raised PSA, usually fairly modest raised levels of PSA. One of them being PSA is proportional, for starters, to the actual size of the healthy prostate. So the bigger the healthy prostate, the more PSA it potentially will produce. Also, you can get inflammation in the prostate without having any symptoms. And that's a very common finding, and that can produce usually chronically mildly elevated PSA levels, or indeed fluctuating PSA levels. And I mentioned things like, for example, urinary tract infections. They can cause dramatically high PSA levels. Any form of instrumentation will cause transiently raised PSA levels. And indeed, even sexual activity in some people will cause transiently raised PSA levels. And for those reasons, that's why I say, really, don't hang your hat on one test, confirm it with a second. So what precipitates a referral? Well, the bottom line is, if your PSA is higher than it should be for your age, that precipitates a referral. So you have your PSA checked, confirmed a second time. If it's still elevated for your age, even only modestly, that should precipitate a referral to your local logical department.
Thank you. That makes perfect sense.
Yeah, and just to emphasize again, I mean, it's, as I say, the arrival of PSA has revolutionized the whole disease because it's turned it on its head in terms of the ability now to pick up early treatable cancer. But there are caveats, as I've just mentioned. Is that fairly clear?
Yes, it did, and I'm sure if there are any further questions that people will raise their hands shortly and put the questions directly to yourself. I'm now going to turn to Mr. Baker and ask a question regarding his talk to us, and in particular when he mentioned the multi-parametric scan. That was quite intriguing because that is quite new. And could he tell us a little bit more about that, please, Mr. Baker?
Sure. So, like I say, things are changing as time progresses. So as we find out more information, people are always coming up with new scanning methods and programs to do things. So basically, the multi-parametric scan involves a few different ways of scanning a prostate. So if you go for a shoulder scan or an E-scan, there's different ways of scanning, and then we look at different angles. The crucial two sort of extra things in here are what we call diffusion weighted imaging, which is good for certain things. In this case, looking for areas which are suspicious. The second one is contrast. So when we give an injection of contrast, which goes into the bloodstream, we basically scan the prostate lots of times in a short period of time, and we can see the pattern of blood flowing into the prostate and out again, and that gives us again another dimension of understanding of how the prostate is in terms of its health and the blood supply as well to it. So that can give us some extra information, which these sort of things are reasonably new. So yeah, so that's basically not every place is able to offer it as well. That's why I mentioned earlier, to make sure that, like I say, some people end up going privately, or they might pay for a private scan. So just to make sure that when they do request it, that they are able to offer this, because, like I say, it's not available absolutely everywhere. Does that answer your question?
It does indeed. Thank you very much, Mr. Baker. I'm sure everyone else has also learned a lot about this scan. And if I may, we have Dr. Jackie Lewis, who would like to put some questions to our panel. Please go ahead, Jackie.
Thank you. For Mr. Collins, thank you so much for your excellent talk. I just wanted to ask, so as a retired GP, obviously I'm familiar with the symptoms as you described, the hesitancy and frequency and passing urine at night being very typical of benign prostatic hypertrophy, but sometimes being an early sign of prostate cancer as well. But other symptoms like blood in the urine or in the semen, or low back pain, pain which keeps you awake at night, are you suggesting that these would suggest advanced cancer if somebody's getting them, or might they sometimes, might it not be that far on if you get these symptoms like the blood? And the second question, so sorry, I'll just ask you the two and then give you time. So if a woman has a history of breast cancer and is found to have the BRCA gene, other women in the family might be screened. Should the men, should the sons and other first degree relatives who are male be tested regularly? And if so, should that be at age 50 plus, or should they maybe start younger if there's a history of BRCA gene in the family, or even just if there's a family history of prostate cancer, would you increase the frequency and start earlier for screening?
Yeah, very good questions. You keep me on my toes here. Firstly, hematospermia is, as a rule, not considered a sinister symptom. It is bleeding from the prostate, but rarely due to prostate cancer. It's usually due to inflammation and prostatitis, actually. So while we would always clearly we'd examine the patient, we would always check their PSA, but in the expectation it's probably going to be okay, actually. So it's not a symptom we worry about. Blood in the urine obviously is a serious symptom, no matter what the cause. Again, we're looking more at either bladder or renal cancer rather than expecting to find prostate cancer. But sometimes you do, obviously, a locally advanced prostate cancer. I mean, the prostate is a vascular organ anyhow. And a locally advanced prostate cancer, yeah, definitely could bleed. So while it wouldn't be high in our list of expectations, it's certainly a possibility. But all these patients with frank hematuria are fully worked up anyhow. So that would be my answer to that. Regarding family history, the definition of family history, as I recall, is 3 first-degree relatives. And the thing about family history is, I think your point's a good one, because yes, they should start being tested earlier, because the classic features of familial prostate cancer are earlier diagnosis. In other words, it presents at an earlier age and is generally more aggressive. So any patient who you think is a family history, I would definitely bring things forward to 40 rather than 50. No question about that. But, some people say family history because their father had prostate cancer in his 80s. Well, that's just random prostate cancer. It's not a genetic familial one. But certainly anyone with brothers and a father who were diagnosed at a young age or youngish age, and I'm talking maybe around 60s, yeah, well, definitely you would consider them as a high risk category. And yeah, absolutely. And then your third question, which I'm afraid to say I probably can't answer, actually. The BRCA gene. I mean, the two things are there's BRCA1 and BRCA2. Now, BRCA1 in breast cancer has a very high risk of breast cancer development. I think 80%, and BRCA2 I think is 50%. It's the other way around in prostate. I think the BRCA2 is the main anomaly. But being totally honest with you, I do not know the association between siblings and the risk of BRCA expression. So I just haven't come across that. It's a very interesting question. So I don't think I can answer that, unfortunately.
Thank you very much. And in a way, it's a relief that you don't have all the answers, because just shows you're human, and perhaps we can investigate it afterwards. And
I'll
certainly,
I'll certainly look into it, because obviously BRCA testing isn't generally available anyhow around the place. And in fact, I tried to get a prostate patient checked recently, and it proved to be quite difficult, because again, in advanced prostate cancer, there are certain treatments that are very effective in those patients who are expressing that anomaly. So it's surprising it's not more widely available. That will happen, of course. But yeah, I'll certainly look at that's a fascinating question. I'll have to find the answer if there is one, of course. I mean, I won't sleep properly. I'm not going to look at it tonight, but I mean, I'll definitely look into it, no question.
Thank you. Thank you so much.
Thank you for that. Before we ask our audience for any more questions, there was one question in the back of my mind for Mr. Knight when he was sharing with us his story, and that is, were there any changes in the quality of life before and after the diagnosis? And this is a question for Cedric Knight, if he would like to share his thoughts with us, please.
Yes, I've already mentioned the the effect the radiotherapy had on me while it was in progress, and that lasted till the end of the radiotherapy period. I had a very good employer who allowed me to have time off work until I recovered. I think I was probably off work about 3 months before I was feeling well enough to return. But I can't remember particularly what the symptoms were, just tiredness, I guess, and difficulty controlling my bladder until things started to return back to normal more. And I've already mentioned the ongoing effect of the radiotherapy on the bowel, which is still a problem now, but I've learned to live with it.
Yes, that is very much understandable, and thank you for that. Thank you for sharing that story with us. If there are any questions from our audience, please just put your virtual hand up, and then you will have the opportunity to ask a question before we ask Dr. Jackie Lewis for her concluding remarks. I did see 1 or 2 questions in the chat, if anyone. Right. Now, Benjamin asks, unless Benjamin wants to put the question himself. Are you there, Benjamin? You can unmute. Okay. So the question was, should one get PSA test regularly after a certain age? I ask this as you say there are normally no symptoms pointing towards cancer, and that was the question. Perhaps Mr. Collins would like to give us his thought on this.
Yeah, I mean, I think the answer is, yes, absolutely. I think from 50 onwards, you should think about having an annual PSA. Now, if you're having bloods for any other reason, that's easy to do. If you're not, then it's not so easy to do because you need to motivate yourself to get it. And your GP has to be willing to do it. Not all GPs are happy doing, that's effectively a screening PSA. And because of the controversy over screening, not all GPs are happy to do that. But they should be happy to do that. And yeah, certainly we would recommend from 50 onwards to try and get an annual PSA. I mean, it might be a year and a half, 1 year, and it might be 6 months the next, but just try and get into that habit, yes, for that very reason.
I just mentioned difficulties at the moment getting blood tests. I had blood sugar blood tests recommended to me by my GP, and then I rang the phone number that you do to get an appointment, and it was a month and a half away. So I took the opportunity when I got to 2 weeks before of ringing my GP and saying, I'm due a PSA test about now. Can I have it at the same time? And they said, well, it's 2 weeks early, but yes. So that's how I came to have my PSA test a couple of weeks ago. So you've got to be aware of what the background conditions are.
Yes, indeed. Yeah.
Yes, absolutely. Dr. Lewis, I believe there's a question there for Mr. Knight.
So sorry to hug things a bit, but Mr. Knight, I just wondered, because you say you're still 15 years on, getting some side effects from the radiotherapy, looking back, do you wish that you'd had surgery rather than radiotherapy? Or are you happy that although there are still side effects, that they're tolerable enough and that you're happy with the treatment that you received?
As I said earlier, I don't remember the decision process in deciding for radiotherapy rather than surgery. My wife was with me at the time, and we must have had a bit of time to discuss it, but I think we had to make a fairly rapid decision. Well, I suppose we could have come back later and said we changed our mind. No, I don't think I have any regrets. The ongoing side effects are manageable, and they were the subject of my referrals back to the Christie over the 5-year period, and they prescribed the medication that I needed to control my bowel movement, and it works generally most of the time.
So it's been a nuisance, but manageable, and 15 years past diagnosis, so it's clearly been fantastic.
Yeah, exactly.
Yeah, we're so delighted to have you here to tell us the tale. One other thing, just so sorry. How about the biopsy? Do you have much recollection of that? Because people worry about the discomfort of a biopsy, but
I remember
what
where
would you
I
say
went.
on that?
I remember which hospital I went to for it, and I remember that it was a bit scary thinking in advance about what he was going to be like. And I think in the end, it wasn't as bad when it happened as I thought it might be. But it is 15 years ago.
Sure, but that's very good to hear. Thank you.
That is amazing. I'm absolutely amazed at the amount of information that we've received tonight and how useful it is, and it's making me question whether I myself, and I'm sure others are doing the same, whether I'm taking this as seriously as I should be. I'm sure that we're all learned a lot tonight, and that we will be doing our best to try and deal with this difficult problem in a way that we are on top of it, and that we're having regular screening and regular tests and so on and so forth. I will stop there, and I will ask Dr. Jackie Lewis for her concluding remarks.
Jay?
Yes,
I've been
go ahead.
for the past 15 minutes.
Yes, go ahead.
No, it's just, what I want to do is just my experience. I was diagnosed on June the 4th with having very early stages of prostate cancer. And part of the proceedings, it's almost been amusing. So last December, I had the November, the PSA done, and I got a letter, and I get the impression that sometimes there's people in the system are very blasé about it. So I got the letter from the surgery saying after 3 days, phone in to make a non-urgent appointment with the GP within the next 3 weeks. So I had an appointment 3.5 weeks later to be told that I'm going to be put urgently on the cancer pathway, and everything had to be sorted out within 2 weeks, which was a little bit difficult because I was due to go on holiday. In that time, as it happened, although I had an enormous prostate, size of a basketball almost, there was no sign of any problem. Actually, it wasn't the size of a basketball, but it was very large. That was in 2019, and then things, delayed. I had the MRI scan, then I had to go for another one. It was supposed to be 12 months later, but it was delayed till March. And the whole process was possibly the hospital. It seemed very, very like a days ago. It was like 19 plus 20. It was 40 days before I heard anything from the consultant. And then it was I think it was a total of 3 months before I got a phone call saying, "Oh, we've got an appointment with you with the consultant in 2 days' time," which so it's obvious what the problem was. But the thing is, in my case, it's been caught very, very early. It was almost congratulatory that I've got a cancer which is likely to cause me very, very little life change, anything like that. But what's really important, I spoke to people afterwards. I remember speaking to one particular woman socially who was saying her husband was so embarrassed about anything like that he would kind of rather die than go for prostate problems. And I think it seems have an attitude like that they just have this terrible embarrassment for a reason I don't know, because if you've got something wrong with you, why be embarrassed? And I think that's something which I don't know if you've dealt with at all, but there's no reason at all for anybody with any symptom not to go to the doctor because they don't want to have a finger put up the internally or anything like that. And I think that point needs to be made. I mean, it's doctors are so used to doing it, and I don't know what it is with men that they won't go. I mean, because I've been monitored and had symptoms for a number of years, that when it did finally show up, it's nice and early, and if it does progress, they'll be able to deal with it. Maybe not with radiotherapy, having heard of what that experience. So,
Mr. Collins, any comments?
Yeah, I think it's a very good point. I mean, I think human nature, to an extent, I think if you have something wrong with you, you feel that there's something wrong with you, and you do feel initially almost, what's the word, ashamed or something like that. I mean, I think culturally that is a factor, and I mean, I think it applies to all of us to an extent. And yeah, of course, you shouldn't feel like that, and you shouldn't be embarrassed. But I think it's understandable that people are. And I mean, the thought of being examined by someone like me or my colleagues is obviously not an attractive one. And the thought of maybe having to go for a biopsy, which is going to be a similar but slightly more involved process, is certainly not attractive. So I think it's a very good point, but it's a bit like telling a patient, don't be nervous. I mean, it just makes no sense. You'll only make them more nervous, The point is that's how people feel. And no, don't feel like that. But I sort of understand why people do. And I don't know what you can say to make them not feel like that, but just to try and stiff upper lip and just bite the bullet and get tested.
In the initial examination, it's like, oh, I wasn't expecting that for the first time.
Yeah.
And it's almost funny. You go to speak to your friends about it afterwards. I mean, it's any embarrassment is short-lived. The biopsy itself, in my case, is madly painful. But I'm lying on my back in the same position as a woman giving birth, and I'm quite sure it's nothing like as painful as that. And what do? You're there for your own health. You go there and you experience it and go through it, knowing that all being well, if there is something wrong at that stage, there likely is something wrong with the biopsy, that a lot of good things can be done. It's
Indeed.
just.
Yeah, my only point of that, obviously, having someone like that, if you had someone like that someone could talk to, then I think that would be very reassuring for them. Someone who'd had it and said, look, it wasn't great, but what the hell, glad I did it, I'm fine, blah-de-blah. Having people like that is so valuable, I
mean, the worst thing, the whole procedure was the first time I had an MRI scan, and I was terrified of going into a little tube head first. And that I was fretting about that for 2 weeks. It was just, the idea was terrifying. In the end, I went in feet first, my head was out all the time, and it was fine.
Yeah.
Thank you for that, Michael. Thank you for sharing that valuable story with us. I'm sure we could sit down and talk about the subject for hours, because it's fascinating, especially when it affects so many of us. I will now turn to Dr. Lewis for her concluding remarks before we end the evening, and for her thanks as well.
Thank you, Jay. Thank you. So we're all so very grateful to Mr. Collins for giving up his evening on our behalf and educating us so clearly, giving so much detail on this really important topic. When we're all so much more aware now about prostate cancer. So that's very helpful, very, very important. And also to Martin Baker for explaining so well about MRIs. if any of us, not just the men, needing to have an MRI for any reason, will know much better what to expect and how to prepare for it. And also thank you so much to Mr. Cedric Knipe for your frank discussion of what you've been through. And again, can I reiterate how glad I am that you're 15 years since having had the treatment, looking so well, and very, very grateful that you've joined Macmillan as a volunteer to help other people. As Mr. Collins said, being able to speak to someone who's been through it is perhaps the most valuable thing of all. And to all the men in our audience and all the women who are representing the men in their lives in our audience, I just hope you're going to feel more confident that if there are symptoms, that you'll go forward to the GP, but ideally before that you'll approach your GP and say, actually, I'd like to be tested regularly. I've hit that age of 50 and I'd like to get that annual test. But you might just need to put it in your own diary to make sure that that happens, because otherwise it may not happen as regularly as you'd wish. So you have to be the driver for that. Thank you so much also to Jay for being an excellent chair and Zoom host as always. I think it's been an excellent event.
Thank you very much, Jackie. And on that note, I wish everyone a good evening and see you next time.
Thank you.
Thank you very much. Thank you very much, everybody.